So my talk is basically focused on the clinical and radiological assessment of skeletal malalignment in children. So I think the aim of clinical and radiological assessment is to basically establish what normal is and what abnormal is, then establish what the etiology of that skeletal malalignment is, what are the plane or planes of malalignment, the degree of malalignment, and the effect of malalignment, and then, of course, plan the correction of that malalignment. So what is normal? So this is a paper from Helsinki, which was published way back in 1975, where they looked at around 1,400 children and followed them up longitudinally. And basically they found a pattern. So any child who's born progresses through a pattern up to around 7 years of age. So what is a pattern? So normally when they are born, they have a normal physiological genu varum, which tends to correct by around 18 months of age. And then they tend to overcorrect and go into genu valgum. And this genu valgum peaks at around 4 years of age. And then again they start correcting till they reach the normal adult alignment of a mild genu valgum at 7 years of age. So when you see a child in the clinic who falls within this spectrum of a physiological deformity, then you should understand and reassure the parents that this is normal for him and that things will correct over time. So what is not normal? So if a child presents to you with a deformity, but also complains of pain, or has an asymmetrical deformity, or a severe deformity, or if the deformity has been progressive, so the parents tell you that, it was not like this 6 months ago, but it's progressed rapidly over the last 6 months. Or if you suspect, or if the parents present with other features, such as presence of syndromes or skeletal dysplasias, so then you should suspect that this is not normal and this is not physiological and it needs some kind of investigation and intervention, probably. So basically the etiology is established from the history itself. So most of the time the etiology will be apparent from the history. So the main things to differentiate is whether this deformity is present since birth or has it been an acquired deformity. So in acquired deformity you look for all these etiological factors. There will be an obvious history of trauma if the patient had sustained a fracture. If the patient had sustained fracture around the physis, then certain physis, the development of a physeal bar and a subsequent deformity is a very high risk. Again, infection, so bone and joint infection or infection around the physis can result in skeletal malalignment. Metabolic is a very important factor, especially in our country, with a high prevalence of vitamin D deficiency, which subsequently manifests as rickets. Tumor is rather uncommon, but a tumor with a pathological fracture can present as a deformity. And then, of course, there are miscellaneous causes such as Blount's disease, skeletal dysplasias. So you need to establish all this in history itself. So this is just to give you some few examples. So trauma around the physis, suspect development of physeal bars in the future. So you need to follow them up, observe them, and look for a development of deformity, and you can intervene early to, to prevent progression. So this is another case where there was an infection around the physis, which has resulted in a physeal bar, which you can kind of see on this MRI scan. And then the tumor with a subsequent pathological fracture, and this can result in a coxa-vara deformity. So how do you assess the deformity? So you assess the deformity in all the planes. So you look at the child from the front, from the side, and then you also assess the torsional profile of the child. So again, most of the clinical assessment has now been replaced by X-rays. So we tend to obtain scanograms and then assess the deformity on scanograms. But clinical examination still remains an important aspect. So in the frontal or the coronal plane, you look at the intermalleolar distance, especially in a kid with genu valgum. Then you look at the intercondylar distance in a kid with genu varum. And for assessing these, you need to make the patient stand. The malleoli should be just in contact with each other, and then you measure the distance. Or if it's a genu valgum, then the condyle should just touch each other and you measure the intermalleolar distance. Now these values are a bit arbitrary. The important part of clinical assessment is if you subsequently serially follow the child and then you're seeing correction of these distances, then that's how you can monitor progress. You can also measure the femorotibial angle, but again, this is better measured on X-rays rather than clinically. This particular picture is basically taken from one of an Indian publication. So this was published from CMC Vellore by Vrisha Madhuri. And basically they developed this long-handled goniometer, and then to measure the alignment of the femur and the tibia. Sagittal profile, you look at deformities around the knee. So this one has a flexion deformity, or otherwise you can also have a recurvatum or a procurvatum deformity in the tibia. This is a child with rickets. And of course, torsional profile, you look at the range of rotations in the hip, so internal and external rotation in the hip. You look at the thigh-foot angle. You look at metatarsus adductus. You look at flat feet or out-toeing. And you also observe the gait of the child. So in the gait, whether the child is walking with the feet turned out or feet turned in. You also look at the child from front, and you observe the patella, whether the patella are facing inwards or outwards. You also assess the leg length. So this is an important part of any skeletal malalignment assessment. And you look at apparent length, true length, and then you also measure segmental length of the femur, tibia, and the foot. So without going into too much details, we all know what the apparent and the true lengths are. So apparent length is from a central fixed point like the umbilicus or the pubic symphysis, and the true length is from the ASIS to the medial malleolus. And you can get apparent lengthening or shortening if there is a deformity in the hip, so abduction or adduction deformity. You look at the effect of malalignment. So if you're observing a malalignment in the limb, then you must examine the spine. So the general dictum of joint above and joint below. So this particular example that you see here is basically a CP child who has an abduction contracture on the right hip that has resulted in a pelvic obliquity and a compensatory scoliosis of the spine. And it is also resulting in now the hip subluxing out on the other side. So when you examine one particular limb, you also examine the other limb and the joint above, which is the spine. You also look for compensatory deformities. So sometimes you will observe a child who's got an in-toeing or an increased anteversion of the femur, but then he will try to compensate by extorsion of the tibia. So you look for these kind of compensatory deformity pattern. And then you also observe patterns of deformity. So you sometimes see a child with genu valgum who's got flat feet, or genu varum associated with tibial intorsion. General examination, not to miss, is the joint hyperlaxity. So you always do the Baton score, because many of these children who are kind of on the borderline of physiological deformities, they do have these generalized hyperlaxity, and you need to reassure the parents that as the child grows older, the hyperlaxity will decrease and the deformity may progressively correct. You also do the general examination to rule out any syndromes or associated skeletal dysplasias. So now coming to the radiological assessment, the most important aspect of a radiological assessment starts by taking an appropriate X-ray. And now there are standardized protocols for taking X-rays, or what we call as a scanogram popularly. So the patient must be in a standing position, the patella must face forwards, and the distance of the X-ray tube to the patella is around 110 inches. So this is for the AP view, and you also do a sagittal profile or a lateral view, again with the patient standing, again with 110 inches between the X-ray tube and the patient, and with the heel and knee externally rotated, touching the X-ray cassette. So the aim of any deformity correction is this should be the eventual alignment of the limb. So you draw a mechanical axis, and it should pass through the center of the hip joint, center of the knee joint, and center of the ankle joint. If there's any deviation from this, then that's what you're aiming to correct. So what are the normal joint angles? I know that this is a very busy slide, and you don't have to actually sit and calculate all these angles. So there are basically 3 or 4 angles that you look at, and these angles are the lateral proximal femoral angle. This can be either mechanical or anatomical, but we mostly tend to focus on mechanical. Then the lateral distal femoral angle, the medial proximal tibial angle, and the lateral distal tibial angle. And you also look at the joint line congruence angle, which is this here. So normally the joint lines should be parallel to each other. So the line through the distal femur should be parallel to the line through the proximal tibia. So if there's any deviation, which means that the genu varum or valgum is actually present in the knee itself. Say, for example, if there is somebody who's got medial compartment OA. So that is what the lines you look for. And these are the normal values of the angles that you should probably know. So the more and more you practice with these, the more you become aware of these angles. And then subsequently you're planning your correction. So I've taken this mnemonic from this particular book. It is quite a straightforward mnemonic, and it helps you go through the exact same process of planning every time you do a planning. So it's called MAP the ABCs. So MAP basically is you measure the mechanical axis deviation, you analyze the joint angles, and then you pick the bone which is deformed. So I'll come to that. I'll come to each of these steps. And then the ABC is basically you locate the apex of the deformity, then you plan your bone cut, and then you do your correction. So mechanical axis deviation is very simple. So if there's a genu varum, the mechanical axis deviates medially. If there's genu valgum, mechanical axis deviates laterally. And then you measure the distance between the center of the knee joint to this mechanical axis line, and that is the mechanical axis deviation. Your aim of any correction is to get the mechanical axis to the center of the knee joint. Then you analyze the joint angle. So continuing with the same example, which I've shown in the previous X-ray. So here you then measure the angle. So you measure the lateral proximal femoral angle, the lateral distal femoral angle, the medial proximal tibial angle, and the lateral distal tibial angle. And you can see that both the angles here around the knee are abnormal, which means the deformity is in the distal femur and the proximal tibia. So that's how you pick the bone. So if you're picking a bone for correction, then you see which angles are abnormal, and then you pick that particular bone to correct. So based on the abnormal joint angles, and in the above example, both the LDFA and the MPT are abnormal, hence the deformity is present in both the bones. So this is what the map part was, and now we look at the ABCs. So A is, where is the apex of the deformity? The older terminology for this, or some people still use it, is what is called as the cora, which is the center of rotation of angulation. Basically, a single level deformity will have one apex in a bone segment. Complex deformities will have multiple apex in the bone segment. There is always this query whether you use the anatomical axis or the mechanical axis. Most deformity surgeons tend to use the mechanical axis when they are planning their correction. However, if you're using an intramedullary device, say for example in a femur, following your correction, then you can use the anatomical axis as well to plan your correction. So how do you calculate, or how do you get to the apex of the deformity? So basically, you draw the mechanical lines, or mechanical axis lines. So you first point out the center of the femoral head, the tip of the greater trochanter, join the two lines. Then you drop a line. You know the normal value of the lateral proximal femoral angle. So you take that angle and you drop a line down. If you don't know the normal population, and if the other side is normal, then you can use the other side value as well for the same. Similarly, for the knee, you draw a joint line along the distal femoral condyle, and then you know what the normal LDFA is, so you draw a line going proximally. So whatever the angle is between the two is your angle of deformity, and where the two lines meet is where the apex of the deformity is. So in this case, the apex is coming to at the physis. So then you have to choose the bone cut. Now, the ideal situation would be where the bone cut is right at the apex of the deformity, so you get a maximal correction without a significant amount of translation. However, this is not feasible in most cases, especially if you look at this example of ours. We can't cut the bone through the physis, so we have to cut the bone away from, sometimes we have to cut the bone away from the apex of the deformity. When you cut the bone away from the apex, then you always get an obligatory translation. The amount of translation is basically the distance between the proximal and distal axis lines at the level of the osteotomy. And the amount of translation should never exceed 50% of the cortical diameter at that level. So again, taking back the same example, so this distance is the amount of translation you're going to get if you make the osteotomy at this level. The correction, you can do it acutely, which you tend to do in most of the cases when there is no limb lengthening or shortening required. Or you can do a gradual correction with an external fixator like an Elisa Rao or a Taylor spatial frame. The correction is usually, so basically you find out a correction bisector line. So I'll come to that in the next slide. And then you take a thumb stack at which is the rotational point at the level of the C level. So what is the C level? So C level is basically this line. So you have drawn the mechanical axis of the deformity. This is where the mechanical axis is meeting, which is the apex of the deformity. So then you obtuse angle, which is on this side, 170 degrees. You bisect that. So that is your C level, or the correction level. Correction level is different from the osteotomy level, which is here notified by B. Now, correction level is where you will place your thumbtack. So I'll come to that in the next slide. So, for example, if you're doing a closing wedge osteotomy, you will place the thumbtack on the concave side, and then you remove a wedge, and then this rotation that is happening around this point here at the C level. So another example is if you're doing a opening wedge osteotomy, then again you place the thumbtack on the convex side. So here you'll open a wedge because you're rotating the whole leg around this point here, thumbtack. If you put the thumbtack at the C level and at the apex of the deformity, then it will be a neutral correction. So there will be a varus on one side and valgus on the other side with minimal translation. So this is how you see an example. So you're doing a proximal tibial osteotomy. You place a thumbtack on the convex side at the C level, and then you correct and you create an open wedge osteotomy with some amount of distraction and translation. And this is how it will look at the end with your mechanical axis line going through the center of the knee joint. And this is how it would look on our example if you do an osteotomy. Although this is just an example, I'm not saying that we should do an osteotomy in this particular case. Lastly, I would just like to mention about this oblique plane deformity. So oblique plane deformity, so if a child, say, for example, fractures a tibia, he's not going to fracture it in the sagittal or the frontal plane. So the deformity that develops may not be in the sagittal or frontal plane. So what you do in that case is you take an AP X-ray, you measure the amount of deformity, you take a lateral X-ray, you measure the amount of deformity, and then you plot it on this particular graph. So the scale is always 1:1. So 1 millimeter is equal to 1 degree of deformity. So for example, if this patient has 17 degrees of deformity and 15 degrees of deformity, then you just convert them into millimeters and plot it on this line. You take the slope of that graph and you measure that distance. So that is a 23 millimeters. So that 23 is the amount of, or the degree of deformity, and the plane you will get by calculating the angles. So in this particular example, you get a deformity which is 49 degrees anterolateral from the sagittal plane, or 41 degrees anterolateral from the coronal plane. So that's how you will place your hinge if you're doing a gradual correction with an Elisa Rao. So you'll place it in perpendicular to this particular line. Okay, so that's about it. Thank you.